Hello and welcome everyone to today's webinar, Shoulder Labral Tears and Bicep Tears. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Amanda Barnett and I will be the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a QR code where you can access a presentation evaluation form. If you are seeking a CEU credit along with your certificate of completion, please take a moment to complete this form if applicable. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, a certified case manager, certified nurse life care planner, legal nurse consultant, and a certified health professional life care planner. She has worked as a nursing professional for over 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services, as well as vocational expert witness services and case management. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the Universal Life Care Planner Certification Board. She is also an active member of the Association of Rehabilitation Nurses, the International Association of Rehab Partners, and the Case Management Society of America. At this time, I'll pass it to Cynthia Bourbeau.
Thanks, Amanda. And I'm very excited that you're all here with us today for a couple of reasons. One of them is this year is our 25th anniversary of being in business. And so we're very excited about that. So everything that we do this year is going to have just that little bit more excitement to it because we've achieved that milestone. So I'm excited. Before we get started, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series. It's designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments both common and uncommon within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and the potential obstacles, and answer your toughest of questions. So get your questions ready. We'll be excited to see them at the end of the presentation. For this year's first Injury Insight session, shoulder labral tears and biceps tears, we're pleased to have Dr. Sean Rockett. So not only are we pleased because he's a great physician, but we are just so happy about his involvement with all of our patients that he's treated, and also has been a big supporter of this educational program, and it has always made himself available to us. So I'd like to say thank you to Dr. Rockett for that. Dr. Rockett has been with Orthopedics New England since 1999 and is the senior partner. A native of Brookline, Dr. Rockett received his Bachelor of Arts degree in biology from Harvard University. Following that, he completed his medical degree at Tufts University School of Medicine in Boston and his internship in general surgery from Tufts Medical Center. From there, Dr. Rockett finished his residency in orthopedic surgery from the same institution. In addition to his clinical and surgical duties at Orthopedics New England, Dr. Rockett serves as assistant clinical professor at Tufts University School of Medicine. He has been a coach for the Wellesley football, baseball, softball, and soccer youth teams. When he's not seeing patients or teaching students, Dr. Rockett's outside interests include art history, ancient Greece and Rome, and spy novels. Since 2012, Dr. Rockett enjoys being the head orthopedic surgeon for the CrossFit Games. Additionally, he is a triathlete and CrossFit Level 2 certified. He is the author of the injury prevention website for athletes called 321gomd.com and author of the injury prevention book, Where Does It Hurt? And with that, I turn this over to Dr. Rockett to begin and say thank you again, Dr. Rockett, for being here.
My pleasure. My pleasure. It's 3, 2, 1, go MD. It's how every CrossFit workout starts. So that's the play on that. I am going to share my screen. Um, and here we go. Can you guys see it?
Yeah, looks great.
How's that? All right. Yeah, I'm happy to be here and thanks for having me. A lot of what I see is dealing with shoulder labral tears and biceps tears and and sort of figuring out when do you need to act and do things and when can you just treat somebody conservatively. So we're going to talk about that in detail. So uh, Amanda, the tool, there it is. The toolbar was covering my slide. Sorry about that. So yes, we're going to look at how to make the diagnosis and looking at treatments and recoveries, and most importantly, return to work and return to life and functioning. So, looking at the slide here, we're going to talk about the anatomy that's relevant to the labrum and the biceps. We're going to talk about the proximal biceps, and then that's going to be the first part. And then the second part, we're going to talk about the distal biceps down by the elbow. So we're going to look into common mechanisms of injuries, conservative versus surgical pathways. How do we know when to go conservative and when to go surgical? We'll talk about that. Recovery timelines for both conservative and surgical, and return to work expectations. When do we tell people the timeline? Do we, and we'll get into it, but I like to lay out that timeline right from the get-go, right at the beginning of almost our first meeting, talking about what expectations somebody can have with this. And I think just talking with the patient, the nurse case manager, anybody who's involved, any kind of employers, always important. Open lines of communication, very important when you're dealing with something as complex as a shoulder workers' comp injury. Why does the labrum and the biceps, why does it matter? Because it's very common with people who do lifting and overhead work. MRIs can provide 8 different diagnoses on a shoulder exam, and you have to sift through it, and a good surgeon or doctor will sift through it and figure out what needs treatment and what doesn't need treatment. Um, these return to work decisions, can impact claim duration, and sort of getting a good diagnosis early on is really very important in my opinion. Um, and again, laying out those expectations right off the bat can help decrease any kind of conflict or disagreements later on in treatment plan. So looking at the shoulder, this is a picture of the glenoid with the labrum. The biceps comes in at the top, or the superior labrum. The biceps becomes confluent with the superior labrum at the top. Um, the labrum is what the ligaments attach to, and the ligaments attach to the humerus. This is the picture where the humerus is removed, and then they also attach to the glenoid, and they attach to the glenoid via the labrum. And around the ligaments and around the capsule is the rotator cuff. And I like this shot because it shows when you have this is the most common labral tear that we see is the Bankart labral tear, the inferior labral tear. That's anterior. That's on the right side of that slide. That's the front. So that's anterior, inferior labral tear. And you can see if somebody has looseness of their joint is because that labrum is not attached. That ligament is then not attached, and then that shoulder can lean, ride forward, and pop out. So having an inferior labral tear can cause instability. If you have a labral tear that's flipping around in the joint, some people will say they feel that clicking or mechanical symptoms. And then looking at the top of the shoulder, the superior labrum, again, that's where the biceps attaches, and that's called a slap tear, the superior labrum anterior posterior. And you can have a bunch of different types of slap tears. Some are just mildly torn or frayed, where that superior labrum is just pulled off a little bit, and then you can have some where it's really pulled off, and and the biceps then can become a problem with that. And then we had that anterior labrum. On this slide, it's to the left, the anterior labrum, and that's called a Bankart. That's given the name of Bankart tear. And then you can have a posterior labral tear, and that's on this slide to the right, the posterior labrum. And then you can have just degenerative or frayed labral tears, as opposed, where that labrum itself is just worn down and not detached, but just worn down. So the slap tear, on the left slide, you see a beautiful 21-year-old biceps attaching to a beautiful superior labrum. Um, Oftentimes you want to probe that superior labrum, and you can see on the right where the probe is actually lifting up that superior labrum. So that is a definite slap tear where that superior labrum pulls off, and then the biceps can get involved because the biceps isn't as attached as it used to be, and people will then develop pain as a result of that. The most common mechanism is a traction injury where your arm actually just gets pulled forward, um, or sort of overhead activity where your arm gets pulled back, where you rotate back. Um, it can happen if you fall, if you land onto your arm, onto an outstretched arm, or even landing directly onto your shoulder, or even just with repetitive lifting, repetitive uh, traction. You can have tendonitis or tendinopathy, which is an overuse and partial tearing from overuse of the biceps. And you can see on that left slide, you see the picture of that biceps. There's inflammation in the biceps. You can start to see some macro tearing, which is, tearing at the bottom of the biceps. And then when you do have that kind of tendinopathy, that actually is microscopic partial tears, and that inflammation is the body coming in and trying to provide a blood supply there to try to get that tendon to heal and try to get it back to normal. Um, Sometimes if you have a sudden heavy lift and the weight is too great for the person to lift, that biceps tendon right at the attachment can pull off, and you'll get a Popeye deformity as you see it on the right, named for the cartoon character. Sometimes these biceps tears can occur with labral tears. Also, it depends on where that biceps is torn. If it's torn directly from the joint, the whole biceps tendon pulls away. But if it's torn in its mid-substance, you then have a piece of biceps in the joint and then a piece of biceps pulling down the arm. And then when somebody tries to move their arm, they'll have a clicking and a pain deep inside the joint if you have a biceps tendon that is still attached, but the tendon tore mid-substance. So it tore right in the middle of it. And you can imagine a piece of biceps like the one on the left flipping around the joint because it's not attached. People will often say they'll have pain and clicking with that, which would involve going into the shoulder to debride that little piece of tendon and then going in to reattach the biceps deformity. Um, so common injuries in the workplace, falling onto the outstretched arm, heavy lifting away from the body where you're lifting this way and that puts traction on the biceps, sudden yank on the arm if the arm gets pulled forward, or again, like repetitive putting boxes up overhead repetitively, that does stress the biceps and the superior labrum. Common symptoms. People typically with the biceps, they'll point to the front and they'll say it'll radiate down their arm. So I'll show you into the biceps. People will often say that. If it's a biceps tendonitis, they'll say that. If it's a partial tear of the biceps, or if it's a slap tear, they'll point directly right into the front of the biceps versus down the side. Um, the pain is deep in the shoulder, clicking and catching is common, weakness with overhead activities, and trouble sleeping. Pain at night. When you sleep on your side, the biceps can get sort of pinched in between the glenoid and the humerus. And sometimes people will say it hurts them to sleep at night. Very common symptom. Picture on the right is a biceps tendon that's torn. As you see, that you have this frayed edge flipping around in there. Common physical exam tests for a slap tear, a positive speed, which is where your arm is held up and the examiner is pushing straight down. That's called a positive speed test, and that will reproduce symptoms in the front of the shoulder. And then you have the O'Brien test, which is this, and the examiner is pushing down on the wrist. And then if somebody says, yes, that hurts, you rotate the wrist and then push up. And the classic positive O'Brien is people say that actually feels better. And what that is doing is this is putting tension on the biceps, and this is relaxing the biceps, taking the tension off the biceps. For a inferior labrum, you have this thing called the positive apprehension, and what that picture on the right is showing this person in a position of apprehension. And what that does is, if you have a tear of the labrum in the front, that causes the ligament to be torn, and it causes the shoulder to then ride forward. The other test is called the positive Job relocation, where a surgeon or a doctor will push back and they'll push the shoulder back into the socket. And people will say, if somebody has a tear in the apprehension, they'll say, oh, I don't like that, that hurts. And then the Job relocation is pushing it back in. And a positive Job relocation test means that somebody says, yes, that feels better because you're reducing the shoulder and taking the pain off the shoulder. Other parts of the exam, you always want to check range of motion. Frozen shoulders can mimic any kind of shoulder pain, so you always want to make sure somebody has a full range of motion. If somebody comes in and says, "Oh, I have pain and it hurts when I move," and they literally can't lift their arm or they can't get their arm up off to the side, and even I can't get it up off to the side, and that's the definition of a frozen shoulder. We get x-rays just to, number one, see if, we see everything in orthopedics. We see sometimes there's a reason why the bone hurts as there's something in the bone, like a growth or a tumor. You can see calcium deposits, calcific tendonitis, you can see. You can see loose bodies. And then the other things you can see are fractures. If you have a dislocation, you always want to make sure you don't have a fracture. And then also arthritis. Arthritis can mimic some conditions, and you want to make sure somebody has a normal ball and socket joint. For the labrum, we will sometimes order an MRI and add an arthrogram, which is where we put fluid into the joint. And what that does is it increases the sensitivity of picking up a labral tear. Sometimes you'll have a labral tear and say that's the tear right there, and on an MRI it sits like that. But if you add fluid to it, the fluid will cause contrast. It'll come in between. It'll show it. Excuse me. So when you get the MRIs, you always want to make sure that the MRI findings add up to what you're finding at the time of the exam. On this image, you see an inferior labral or anterior Bankart tear. And on the right, you'll see the ball up above, and you'll see the labrum is detached from the glenoid, from the socket. And that's a probe that's probing the labral tear. And this inferior labral tear is usually what happens with a anterior dislocation of the shoulder. You can have a posterior subluxation or a posterior dislocation, and then you would have a posterior labral tear. The most common symptom of a posterior labral tear is pain, not instability. So people will say, and they'll even point to the front, they'll say it hurts here. Sometimes they'll say it hurts in the back. And most commonly, they'll say it hurts if they come across their body and reach like that. It'll hurt in the back because that stresses the capsule in the back of the shoulder. If somebody has, say, a subluxation instead of a dislocation, or they just tweaked it and they have a small labral tear, or a small tear, or even just fraying, and the mechanism of injury wasn't severe and their symptoms aren't that bad, they feel pretty good, but they have some soreness. That's usually when I would look at non-operative treatment or physical therapy. Obviously, anti-inflammatories can help with pain. modifying what they do can help reduce some of the strain or some of the pain that they have. And then occasionally a steroid if a bursitis is involved or a tendonitis is involved, but the steroid doesn't help, the labrum heal, as we know. Typically, for a small shoulder issue, it would be 6 to 8 weeks of timing and therapy and hopeful improvement with modified activity being done during that recovery phase. And then hopefully by 2 months, they would be back to full activities. So when do we think about surgery? If somebody definitely dislocates in a young person or a laborer and they have overhead activities that they have to get back to, that would be an indication for surgery. You see here the picture of the labrum being detached from the front, and then what happens is you get a divot in the back of your shoulder. That's called a Hill-Sachs defect or a Hill-Sachs divot. So yes, an acute tear, acute dislocation, young labor or heavy labor, overhead labor who needs their shoulder not to be stable and not to dislocate, that would be an indication for surgery. What do you do? Typically, it's an arthroscopic repair where we use anchors. We put anchors into the bone. We pass the sutures that are attached to the anchor through the tissue, and you can see this nice, secure repair of the labrum and the ligament, pulling it up to the glenoid. Um, Sometimes you'll have an instability event where the shoulder will pop out or be loose, and there will be no tear, even on MR arthrogram. And so sometimes it's in somebody who might have loose ligaments to begin with, like a 20 to 40-year-old lady who sometimes has looser ligaments than men. Um, and the shoulder can sort of feel droopy, feel loose, feel like it's going to pop out, not secure. And if they show signs of ligamentous laxity or loose ligaments, like they hyperextend at the elbow or their thumb comes way down and can touch their forearm, that person might have multi-directional instability without a labral tear, and that person would work on physical therapy for probably at least 2 to 3 months. But then if things are not improving, there is something called a capsular plication, which is looseness of the shoulder being treated by tightening up the capsule as opposed to a labral repair. When you have a biceps tear, say a complete tear or a slap tear, and things are not improving and not getting better with therapy, you can do what's called a biceps tenodesis, and then you would debride inside the joint the remaining biceps tendon that was inside the joint. And this slide brings up my point, where if you have the tear in the middle of the tendon, the biceps has a very long tendon part. You have a tear in the middle, you have a large piece in the joint, you have to debride what's inside the joint. And then you can then reattach the remaining tendon with a screw or an anchor into the humerus, and that's the picture on the left showing the biceps tenodesis, where the biceps gets secured or anchored into the humerus. People say, what happens if you leave the biceps, if it's a complete rupture and you leave it there? I oftentimes will see somebody complain of cramping or weakness, especially if they're trying to reach up in front of them and reach overhead. If you have that Popeye deformity, I've had people complain of that. The cramping is and I know this because I'll go in on a biceps tendon that's torn, there'll be scar tissue in the biceps and it'll be attached to the short head. And when it contracts, it pulls on the short head and it actually is a sudden jolt and people notice the difference and the people that develop that don't like it. Um, so if we did a labral repair or a biceps tenodesis, excuse me, you do a sling for 4 to 6 weeks, begin PT and early active assisted motion, strengthening at 6 weeks, and then full recovery hopefully by 4 to 6 months. Um, Similar with a biceps ten. I'm sorry. So that was a labral repair for a Bankart. I was thinking of a slap repair. This is a labral repair for a Bankart, and that is, yes, what we said, 6 weeks of strengthening, full recovery, 4 to 6 months. A biceps tenodesis, where you anchor it, it's not as you can be a little more aggressive with it, still strengthening by 6 weeks and return to heavy lifting typically by 4 months as opposed to 4 to 6 months. I've even had people by 2 or 3 months even feeling really good on the biceps, but they still have to be careful because they're still healing. If you do a comparison of return to work, the distal biceps is typically about a 4 month recovery. The labral repair, because you're getting into full, range of motions of the shoulders, getting into about a 6 month recovery, 5 to 6 month, I would say. The biceps tenodesis is still about a 4 month, and then a non-operative labral recovery can be, 8 to 10 weeks. If you tear your proximal biceps, what we said is you do have a deformity. People hate the deformity. They hate the way it looks, but um, the question is, can you leave it? And yes, you can leave it, but again, some people notice some weakness, and some people notice cramping, and that gives them weakness when they get the cramping when they try to lift. So usually, if somebody's reasonable health, a laborer, young person, I would perform a biceps tenodesis. Light duty is certainly reasonable with that, and that could be desk work even within 2 weeks. No lifting greater than a coffee cup for, say, the first 6 weeks, and then 5 to 10 pounds after that, and then avoiding early overhead for a few weeks, but then hopefully by 4 months returning to full. As we said, heavy labor, 4 to 5 months, gradually working up at therapy, gradually doing a functional rehab, doing a work simulation rehab where they're having people do the actual thing that they have to get back to. I find that's always very helpful when a therapist can say, yes, this person just basically did everything that was necessary for the job. Then that's that's very simple for me. Then they come back to me and I say, okay, you just did that. Great, you're going back to work. And it's to have a therapist say, yes, they just completed everything they need to do is great. So some red flags, sometimes the symptoms inconsistent with the exam, depending on the physical exam, pain out of proportion, and that's just sort of getting a feel for where somebody is and how much effort they're putting into the exam. And when I, know what a diagnosis is and I can test somebody's strength and I'll test their strength in a bunch of different movements. If there's one movement that I test that has nothing to do with their shoulder and maybe it's their wrist and I'm testing their strength and they have weakness of their wrist, and those are some things that we can look at to say that this person wasn't giving a reliable exam, or but again, it's rare, but it's just always something to think about. For the helpful tips for the case managers, sort of clarify objective findings. What did you see with the patient? What have they been like dealing with them? Are they, eager to get back to work? Are they, um, canceling visits? Are they, working with you and want to get a diagnosis, or are they canceling multiple visits? Um, finding out how much is pain, how much is stability. Is it your shoulders popping out and that hurts, or it just hurts? That's helpful information that we can have. Making sure the work restrictions are confirmed, that everybody, including the employer, knows that this person is allowed to do light duty. Um, Seeing if light duty is available, working with the employer, oftentimes, you know, trying to come up with different ways to get the person back to work, because we know that getting them back to work, even in a light duty capacity, is helpful for then finally returning to full work. And also making sure this timeline is understood. I will go over that timeline with the patient, with the case manager in the room. I'll talk about when can they get up and move and exercise, when they can drive, when they can get back to work light duty in a sling, when they can get back to light duty without a sling, when they can get back to heavy duty, what kind of, pain is going to be involved, sleeping issues, all things like that. Sometimes we get questions, there's an MRI showing no tear, but surgery is recommended. How is that? Why is that? And that's what the capsule is loose, that we'll talk about capsular laxity. Why does it take so long? It takes sometimes 2 to 3 months for tissues to grow together, then another 2 to 3 months to get stronger. What can the patient do during rehab? Making sure that that is covered completely before surgery, and making sure that even after surgery, the patient knows. Remember, we talked about this before surgery, knowing what they can do, and making sure they follow the guidelines. Um, it is usually not 100% full duty within 2 or 3 months, so there is chance for light duty if the employers can work with the patient. Um, but sometimes people will say they don't want them back unless they're 100%, and that's fine too. So what sort of increases the issues of increases the cost of these cases? What can be done better, I would say. Uh, Getting a diagnosis early on is really important, in my opinion. Somebody might go to a walk-in clinic, then wait 2 or 3 weeks, then see their primary care, and then another person would go to an emergency room and get a note for being out of work for a month, or follow up with primary. I think getting that definitive diagnosis. Sometimes it doesn't need an MRI, but sometimes an early MRI is helpful just to see which pathway we're heading on. Um, you know, a good surgeon will be able to say, like, this seems like this is going to be non-operative, and just get the MRI for confirmation, or non-operative, don't do the MRI, and hopefully within 6 weeks have the patient return back to work. Or early on, if it looks like a really bad injury and somebody has trouble lifting or any kind of motor deficit, then getting the early MRI and seeing if something is torn, like a rotator cuff, as well as a labrum and biceps, etc. So I think getting that diagnosis early is very important. Um, Sometimes getting into therapy is tough too. You'll see somebody with a non-operative labrum, and you'll say, okay, go to therapy. And then you find that the therapist are booking out a month, and that they come back to see you in a month and they haven't started therapy yet. So they say, oh, I need to have my therapy first. And sometimes they do, sometimes they don't. If somebody has got full range of motion, excellent strength, and it was a minor injury, at that point, they don't need therapy. But, trying to get PT early referrals is very helpful. Um, Also, the red flag of the patient canceling their PT visits and then saying, my shoulder hurts because I, haven't had therapy. So, that's a catch-22 there. Again, delayed therapy, having no modified duty available. It's tough to get that person to going from no work at all to getting back to full work at 6 months. It's sometimes very nice and helpful to have a light duty, just so the patient doesn't get out of the habit of going to work and being surrounded by friends, and not being at home on TV all day. Um, Reassurance and reassuring the patient that you did surgery for a reason. We gave it time to heal, and you're strong, and feeling okay getting back to work. That's very important, and that's a good therapist can help with that too, by showing the patient what they can lift and that they're doing well. Um, and then other reasons why things don't progress as well is if, rotator cuff is involved, or they have bad arthritis too. Arthritis can, unfortunately, increase the recovery of an injury. And if you have arthritis, it's more difficult to get rid of swelling and pain after a surgery. Um, Improving outcomes. Sometimes after surgery, you'll have a tight shoulder, or the range of motion won't be as good, and you might need a cortisone injection to try to help get rid of some inflammation. And I've seen dramatic improvements with one cortisone injection. Somebody has a tight shoulder, you do a cortisone injection, and they feel better. Having expectations that you will have soreness for the first 6 weeks, definitely, and then at 3 months, it's still not unreasonable to have some soreness, and being, letting the patient know that soreness is okay, as long as nothing bad happened, you didn't rip, tear, or pop anything after the surgery. Um, Sort of misconceptions that we see, that Surgery, once you have surgery, that means you're out of work and you're going to have disability. Absolutely not. That's the reason we do surgery, is to get people back to full duty and back to work. Um, After surgery, having some strength loss, normal. Having atrophy, normal. Does that mean you can't do a light duty job? No. So, you know, you're not going to be 100% at 6 weeks or at 8 weeks, at 10 weeks. And having a light duty capability is fine as long as you're maintaining the guidelines after surgery. Pain equals failure. Like we see a lot of times people continue to have pain and their shoulder's just very tight. And imagine, you have a tight shoulder, and every time you try to move it, you're pulling on tissue. That can cause pain by itself, and that's a frozen shoulder um, can cause the pain. But some people think, oh, my shoulder's ruined and it's things ripped, and that's where the pain's coming from. No, it can actually be just from a frozen shoulder, which time will take. And sometimes that's what we see. A cortisone injection sometimes can help that inflammation and tightness resolve. So a case example for surgical repair, you have a 28-year-old overhead labor, acute fall onto the arm like that, like outstretched arm. They have a Bankart tear. You do an arthroscopic labral repair on that person, and they're back to work typically by 5 months. Here's an example of a slap tear where a firefighter was trying to help somebody and they pulled their arm or their or the gurney collapsed and they had to hold somebody on a stretcher. That can cause a traction injury to the superior labrum. Typically, if it's not a huge tear, you could try conservative management for that. And then if things did not improve after, say, 2 or 3 months, you could go then to biceps tenodesis with a return to work at 4 to 5 months. So important take-home points, not all labral tears are surgical. Um, some can heal, and some can just quiet down on their own if they're very small. Uh, the imaging does not correlate sometimes with what we're seeing clinically. So being able to listen to the patient, examine the patient, making sure you're not over-treating or treating an MRI, and having good physical therapy early on, attentive therapy can help shorten recovery times. And making sure you have a clear return to work plan is critical. Moving on to the distal biceps, you see the biceps tendon attaching down into the radius. A distal biceps typically pulls right off the bone. It's typically not involved with the bone. It's the tendon ripping right from the bone. The biceps is actually a primary supinator. So supination is that on a right-handed person. Supinating is rotating your wrist. So very important with people that perform screw driving or torquing with wrenches. Supination activity is very important for a laborer. The mechanism of injury can be very different. You can have a sudden load on an elbow, like a heavy object, a heavy garbage bag, a heavy trash bag. People will say that they'll sometimes their arm gets pulled back and they'll feel a sudden pop in their elbow region. They'll have that deformity. Typically, it's males, 30 to 60-year-old. You see the biceps tendon in this picture pulled up towards the shoulder. That's not a Popeye, that's a distal biceps where the biceps has pulled up because it's like a window shade with the distal biceps, it pulls up. So you have pain, swelling, bruising in the forearm, weakness with supination, and then also weakness with flexion, resisted flexion. There's an absent bicep tendon. A normal person, you can feel their biceps tendon. When you have that deformity, you do not feel the biceps tendon, it's pulled away. MRI shows that the tendon has pulled away from the bone. That's the fluid that we're seeing. Ultrasound, sometimes you can see it. You can see partial tears as well with an ultrasound or an MRI. Partial tears can be treated non-operatively, and then sometimes they feel better and return to normal activities, and sometimes a partial tear goes on to surgery just because of pain in their elbow or forearm, and again, weakness with that supination. The treatment for full tear with a young active worker is to reattach it. You make an incision, you go down to that radius, and you anchor the tendon into the bone. You want to do these ideally within 3 weeks. If you're getting into 6 weeks, it's becomes more difficult because of the scarring that takes place and the retraction of the muscles. The median nerve is right near there, and sometimes the tendon and the muscle will scar down to the median nerve, which is really why it's very, very important to get these, even with the proximal, to get these tendons taken care of. Um, so typically, the reason we recommend surgery is you prevent that supination loss, that 30 to 40% of supination loss, or 20 to 30% of elbow strength loss. Again, manual laborers will often notice it with torquing or pulling. Typically, after surgery, it's splinted and then protected for 6 weeks, and then start strengthening by 6 weeks and getting full range of motion. And then typically within 3 to 5 months for heavy laborers, people can get back. Most people notice a major difference with their strength and the way they feel. They feel better, they feel stronger. They might notice some early fatiguing, but that usually clears up. Biggest risk with the distal biceps is sometimes you have a little sensory numbness on the lateral aspect of the forearm. And I would say that's the sort of more common complication that you could see. Otherwise, people usually do very well. Um, so it's usually an acute injury causing the issue, usually in a 30 to 60-year-old gentleman with a laborer. Early diagnosis, early treatment, early surgery prevents prolonged scarring and recovery. And again, just with classic mechanism, mechanic lifting an engine, acute pop, swelling, bruising, surgical repair, and typically they're back to full duty by 4 months. People often say, why don't you repair slap tears, talking about the shoulder and the superior labrum? Um, the return to work is less, and people don't feel as that they get back to their level of activity compared to a biceps tenodesis, where you have a very high return to work and function. And that's just the anatomy of the superior labrum and the biceps is such. I've noticed it early on. We were doing slap repairs, and I've done switched to biceps tenodesis, and it's become a much more reliable surgery, a much more reliable return to work with fewer complaints of pain after the surgery. So ways to shorten claims, get people into therapy, get their assessment of when they can return to work, light duty, full duty, getting therapy to get them up to speed, get them feeling comfortable going back to work, as opposed to saying, well, I don't know, see what the doctor says if you're okay. And, knowing what the patient has to lift in the job and knowing that they just did that at therapy is very helpful. And then just, if somebody needs an impairment rating, the ways to do it are looking at strength, loss of motion, deficits, um, looking at an MMI. Hopefully, again, these surgeries are usually not prolonged recoveries. These are typically not dealing with a year of recovery. These are typically in the months. So, you're not dealing with an arthritic condition typically. Getting objective motion, range of motion, getting their strength back to normal, making sure they don't have any permanent restrictions is important as a doctor and treater to get people back to full functioning without any hopeful anticipated future medical care. And I'm going to wrap it up there. And this is our surgical center at Natick, and we're coming up on, we had our 5-year anniversary, and very happy with the results of our surgery center and being able to take care of patients. So thank you.
Great. Thank you so much, Dr. Rockett. I will now share my screen if everybody can see that. So yes, thank you, Dr. Rocket, for sharing so much information and insight about shoulder labral and bicep tears. At this time, we'll shift into our question and answer session. So please be sure to submit your questions using the Q&A feature within the Zoom dashboard. And if you are seeking a CEU credit along with your certificate of completion from today's webinar, please take a moment to complete that form on the screen using the QR code. So in the meantime, let's take a look at some of the questions submitted for Dr. Rocket. I have a few right here. Let me just get them up quickly. Okay, so first question. With multiple areas of damage of the shoulder, is there a schedule of what you replace first, or do you do it all at once?
Yeah, there are definitely times where it makes sense to do everything at once, because you want to give that person one rehab, one recovery. Instances where I can think of where I would do a staged treatment or a staged recovery would be, say someone had a frozen shoulder and then you need, they have no motion in their shoulder, they're stuck, they've tried therapy and you can't get motion in their shoulder. I would do a release of the scar tissue first, a capsular release to get full range of motion of the shoulder, followed by a surgery after that. So I think that's pretty much the only time where I do staged. If somebody has a Bankart tear and a biceps tear, so an inferior labrum plus a superior labrum, where I'm gonna be doing a Bankart plus a biceps tenodesis, that is fine. They can recover sort of at the same time with those. That's fine.
Yeah, fantastic. So if you repair either labrum or biceps, do patients usually need to have it repeated later in life?
No, no, those results are very successful. Um, getting somebody a labral tear in a young, healthy person, or anybody that dislocates for the first time, getting that labrum back to the socket, that patient usually does very well. The recurrence on that would be a 5% risk of dislocation to 10% risk of redislocation. So that's a small percentage. And then a biceps tenodesis, I've had great results with it. I would say it's exceedingly rare for any re-tear of that. I have had somebody who pushed it early on, like at 2 to 3 weeks. They did some lifting and they did tear the repair. So I've had to go back, but I've done hundreds of biceps and tenodesis and not had a re-tear.
Yeah,
Maybe even
fantastic.
thousands. Yeah.
And how do you handle pain management now with the refocus of narcotic use?
Yeah, these are not that painful. I'd say a rotator cuff is painful. I would say a biceps tenodesis. I've had people take no narcotics because of the block that they get and the numbing agent that we inject into it. Um, and even for a labrum, I haven't. I tell people the average is probably 2 to 3 days of oxycodone. Just, but some people don't even take it that much, and um, we again, it's just not that painful, I would say.
Sure. I'm just gonna check
Easy
it.
easy for me to say, but I have had labral surgery, so I do know what it's like. So it's usually not a prolonged recovery, I would say.
No, fantastic. Okay, great. So I think that might conclude our question and answers.
Mhm.
So we are just about done for the day. We want to thank you all for joining MLCC's first Injury Insight webinar of 2026. A playback of this webinar will be available within 48 to 72 hours. Additionally, for those who have attended live, please anticipate your certificates of completion within 48 to 72 hours. And thank you again to Dr. Rocket. We know that our attendees enjoy learning from specialists like yourself. And our last plug of the day is our second Injury Insight of 2026 will be held on June 10th with doctors, okay, Steve
Mhm.
Paragodakis and Mark Minkowitz on the evolution of spine surgery. So head on over to our website, medicalandlifecare.com, to register for this next webinar. And with that, we will conclude today's webinar. Thank you again for watching to our hosts, Dr. Rockett and Cynthia, and we look forward to the next session. Thank you so much.